Good morning, everyone. Thanks for coming to our first, Zoom program of the academic year. My name is Aisha Dixon. I'm the director of the UCLA Emeriti Retiree Relations Center, and we're so glad to have you join us for this very important topic, advanced care planning. Um, just a little bit of housekeeping. I'm going to mute everyone, so please keep yourself on mute. Use the chat feature to type in questions, and we will take the questions throughout the presentation, but it's important to keep yourself on mute in case there's a rogue animal or contractor or trash person that's picking up things, and we can make sure our speaker has the floor. I am recording this Zoom, so if you need to step out for a bio break or something like that, I will send a follow-up email with the YouTube video and also the attachments. I sent 3 attachments on Friday, so that you have the advanced care directive, the PULST, and whatever the third thing was that I sent.
The presentation.
The presentation, yes, thank you. So also to welcome to our other sister campuses that have joined us today for this topic. We are a small team of 2 that help manage this comprehensive approach to retirement. We do support the Emeriti Association and the Retirees Association here at UCLA. I myself report to Vice Chancellor of Academic Personnel, and through our small but mighty office, we help support over 19,000 retired faculty and staff. So thanks for joining us. I won't take more of your time, but I'll just turn it over to Delia Cortez, who's a palliative licensed care social worker at the UCLA Medical School. And I'll just turn it over to her.
Hi, thank you. Thanks, Aisha, for bringing us together. Can you hear? Can you hear
Yep,
me okay?
I'm just
Okay, thank you
unmuting
for
people, so go
okay,
ahead.
thank you for bringing us together. So as Aisha said, my name is Delia Cortez. I'm a licensed clinical social worker. I've been with UCLA for about 17 years. So I actually work here inpatient at the center.
Sorry about that, Delia. I need to just mute everyone else except for you.
Got
Okay.
it.
Yeah, go
Okay,
ahead. Sure.
great. And so one of my passions is advanced care planning, and sharing this information with people and addressing questions, knowing that this is an option, a choice that people have, especially as one interfaces more with healthcare, is in a healthcare setting. So as Aisha and I, some of you might have heard as we were discussing, please feel free to jump in and I saw a couple questions already in the chat. Feel free to use the chat for questions, or, raise your hand or unmute. I find that the questions really help bring some life and meaning to the presentation. And oftentimes other people have the same questions in the group. So feel free to do that. And so go ahead, I'll get started. There we go. I think this handout wasn't included in the email, but I can forward you, Aisha, this handout. One of the things that I'll be mentioning in this presentation are some reflection exercises to get us thinking about what advanced care planning is, what brings meaning to our life, what defines us. Those are such big kind of global questions. Oftentimes we don't pause to think about that. So this is kind of thinking about what defines quality of life for you. That's something that I often engage patients and families with. And it's kind of like, why are you asking me this in this medical setting? I haven't been asked that before. But as we move through this presentation, one of my takeaways for you is hoping that knowing what quality of life is, how we define it, how you define it, ideally informs kind of what the medical instructions are, what the medical plan of care is, and how that evolves to ensure that the quality of life, that how, again, as you define it, is really at the focus, at the center as you move through this healthcare journey. So at the end of this presentation, what I hope to convey is be able to define what advanced care planning is, for you to be able to initiate an advanced care planning conversation with your family, friends, support system, and be able to complete an advanced care planning document. And please note, I listed their family, friends, support system. I use generally the term family, but please, that's intended to define as you will. There's so many different structures, friends are family, so please interpret that as you will. And so we're on the same page, and also I think this is important to cover as one moves through these conversations, talks to different people, being familiar with terms that are connected to advanced care planning or advanced directive. Oftentimes, we might be asked, who's your surrogate? Who's your decision maker, your DPOA? And so I wanted to break those down a little bit so that you also know when people are asking you or you hear this, you know what these are. A surrogate is a verbal appointment. So let's say I've told my physician, my sister is my decision maker if I become unable to do so. That's documented, that's a verbal appointment. But once I complete an advanced directive or a legal form identifying my sister as my healthcare agent, then she becomes a healthcare agent. And there's also conservator, which is a court-appointed legal guardian. And if none of these exist, if none of these are present, then by default it goes to the closest available relative. And if there isn't a relative, then the closest person that knows you, that has knowledge about, lifestyle, medical decisions, instructions. So just wanted to make sure we're familiar with those terms. So what is advanced care planning? And as we look at this slide, one of the takeaways is to really communicate the instructions that we have for our healthcare. So I'll go ahead and read the definition that I have here. Advanced care planning involves learning about the types of decisions that might need to be made, considering those decisions ahead of time, and then letting others know about your preferences, often putting them into an advanced directive, which is a legal document, and we'll get into what that advanced directive looks like. And really the heart of this is communicating these decisions ahead of time, thinking about them and letting others know what the preferences or instructions are. I often see beautiful documents completed, legal documents, but the person that's listed as the decision maker, the healthcare agent, isn't aware that they're listed as such. They have no idea what their family member would instruct or what decisions they would make. So even though we're going to go through this document, really the heart of this is the communication, making sure we've discussed this with the people we're designating, people or person, and making sure that they understand what those instructions are, because essentially they become an extension of our voice. So we want to make sure things are clear. Yes, we can't predict every scenario, but in a general sense, what decisions might I make? And the goals of advanced care planning. These are ongoing conversations. It often starts like this with education, that this is an option. And so we start with kind of what are the goals of care. It may include resuscitation, life support, may include palliative care options, surrogate decision maker, who might my decision maker be, and that may manifest itself in an advanced directive. Documentation of difficult decisions for when the time comes, especially if a surrogate is not available. Through these presentations, I learn a lot from your questions. And one of the questions that I've received in the past is, what if I don't have someone to designate? Well, then that makes this document even more important, because it allows you to list any instructions, what I often call do's and don'ts of healthcare, and be an extension of your voice. And it includes goals, wishes, values, and beliefs that we hold, and those are reflected in the document and in the choices that we make. So why do we do this? Why plan? Planning is really important, but whether you make plans or not, in most cases, decisions about what care you receive will still need to be made. Our research has shown that more than half of patients, so people that are come through the ER, that come to the hospital, are unable to participate in end-of-life decisions at the time they are being considered. That's a pretty high number, I think. People are often too sick. Maybe they're suffering from some cognitive impairment or decline, or they're unconscious, so they're unable to make any healthcare decisions. And these healthcare decisions, they need to, they are often assessed, as you may know, by physicians, by the medical team, to make sure the person has capacity. And if they don't, then by default, the healthcare system will treat aggressively, even if that is something that we don't desire. Our healthcare systems that we have created support treatments. We wouldn't want it any other way, right? We want to be cared for. Yet when healthcare professionals are uncertain about what a patient would want, the default is to treat, even if one would not want such treatments or interventions. So if they have not talked with the patient about his or her wishes, neither healthcare professionals or even loved ones can reliably predict a person's wishes. It's interesting. The last time I did this presentation, I think we had just come off, and I'm not sure what the proper wording is, but the initial kind of COVID surge, where we were hit very hard that first year, that first summer, and what we had learned from COVID and how that influenced how we talked about our healthcare instructions. And I think still see kind of that ripple effect of that, with still people having that effect, having experienced COVID, including end of life care. And I just wanted to note that might be something that is still kind of residual with us and impacts our decision making. I think we learned a lot during that time about planning, and reminding us that advanced care planning is not for people of a certain age or diagnosis, that we all, it's beneficial to think about advanced care planning and thinking about our healthcare instructions, regardless of age, as well as health status. And like it states here, I think, when we don't talk about such things, and these are very challenging, hard conversations, I don't want to underestimate that. When families are asked to make decisions in these moments of crisis or, heightened need, studies show that they're often left with uncertainty and stress. And we hear that uncertainty and help process that through guilt or depression about making the quote unquote right decision. And there's often financial concerns around these decisions, some implications around that.
I just have two questions. One was sent directly to me, and then I can
Sure.
the other one. So the first one is, if you use this advanced care directive form that you sent us that says California, applicable if you're in another state or out of the country?
Okay, I can answer. I'm going to get into that, but I can answer that. The one that I sent is, you'll notice, and I'll show it in a couple slides, I'll show it. It's a UCLA California Advanced Healthcare Directive. And so there are a lot of advanced healthcare directives on the internet. Should you choose to complete one, or maybe you have one, it doesn't have to be a UCLA one, and actually that UCLA branded one would be accepted in any other healthcare system. And they are state specific. So if you do travel or live in other states for prolonged periods of time, I often advise to look at the advanced directives that they have in that state and complete one there as well. Because this one is specific to California. They generally have the same language, same intent, but each state regulates their advanced directives. We do get, being a large healthcare system, advanced directives from other states. And what we generally do, because we have an ethics committee and certain structures in place, we'll still accept that directive, assuming it's completed correctly and it stands as a legal document, because it still has the patient's healthcare instructions on there, and that's what we're looking for. So we would still take it as a valid document, as a guide on how to treat this patient.
Okay, and then one question before you move on.
Mhm.
If someone doesn't have any family or close relatives, can they just write their wishes and get it notarized? Is there a typical minimum or this default that you were talking about?
That's a great question. In order to complete an advance directive, to complete an advance directive, you can do one of two things or both. One is list your healthcare instructions, what I often describe do's and don'ts, and ideally that comes from discussions with your doctors, with your nurse practitioners, on kind of what the plan of care is, what do the next steps of my care look like, or perhaps it comes also from a prior experience of being in the hospital. I often hear that as well, receiving certain interventions or treatment in the hospital or in a clinic setting, and saying, I would proceed with this, or I don't want this again. And so again, the do's and don'ts, and then you can also designate a healthcare agent. I do see directives that don't have a healthcare agent for a lot of different reasons. And so you can complete the directive and just put your healthcare instruction. And if you're doing that, be very clear and very specific. Again, can't predict every situation. So what's documented in those forms generally is from prior experience, maybe experience from, observing friends or other family members as well.
Thank you.
Thank you. Thank you for the question. So I wanted to cover there's a list of kind of barriers to advanced care planning, if you will, that I often hear and that I've read about. So I kind of want to list these and see if any of these maybe resonate within you, or you've heard these, or you've heard other people say them. And I think to kind of dispel these statements as well. And I think the point of this slide is to hopefully make you realize that advanced care planning is accessible and, if I could say, doable. So some of the things I hear is, I'm healthy. I don't need to think about that. I'll think about it later on. But again, the previous slide, when we are in crisis, we may not be able to engage in discussions about our healthcare and make such decisions. It isn't really necessary until I am seriously ill. Again, ties into the first one. In order to engage in the completion of advanced directive, we do need to be cognitively intact, be deemed to have capacity to make these decisions. So the time to do it is earlier on as opposed to later. My family members and healthcare providers will probably do what I would want anyway. That's often not the case. And as the prior slide demonstrated, if we haven't talked about it, our family members may know us really well, but there's this sense of guilt and uncertainty of, am I making the right decision? And providing more specifics is really a gift to the people that may be involved in these decisions and these discussions. And again, healthcare providers are limited in some ways. Where if there isn't anything like this in place, then we default to a more, if I could say, aggressive plan of care. I do not have someone to list, and we just talked about that. So thank you for the question. You don't have to have someone to list in order to complete an advanced healthcare directive. You can list your instructions, your wishes on the document. How do I know what I want? Wish, instruct. I often get that question. And again, this document, these discussions, we can't predict every scenario, but it's really designed to get a general sense of what decisions we may make based on the information we have. I will do it later, and then later comes and there's a need for the document. So again, sooner rather than later. I think it has to involve a lawyer. What I'm going to show you today, the Advanced Healthcare Directive doesn't need to involve a lawyer, and it's often at no cost. All you really need is the form, and we'll get into the completion in a bit. It will cost too much, and the forms are overwhelming, intimidating. Yes, the forms can be overwhelming. I think oftentimes, the information, the emotions that might come up, and that intimidating factor may cause us to pause and not complete the document. So my best advice is to take it a bit at a time, coming to a session like this, learning about it, then maybe looking at the document next week, looking at one sheet, allowing yourself to follow the pace that feels most comfortable. And this slide is intended to show you what I had mentioned earlier. There's quite a few advanced healthcare directives out there. There's some that look very legal, some that have pictures, and I'll give you there's a reference list at the end of my presentation as well. That's all to say that you can do your own research and Google and look up different advanced healthcare directives. Again, if you're in California, you want to have one that is a California document. I've known a couple of people that travel outside of California for months at a time for weather purposes, weather reasons. And so we've actually talked about this. I've advised a couple of people to look at, the specific state they're in and make sure that they have the proper directive and documents in place. So I really do encourage you to look at them. For me, I find it, or maybe I'm a bit of a geek in this area. I like looking at other directives and what other healthcare systems have. But regardless, if you feel comfortable with the one that we sent to you, which is this one, you're welcome to fill that out. I often advise people to use the first draft as a worksheet and kind of, think it through, talk it through with whoever you'd like to be involved, and then go from there. And so I thought I would just kind of discuss the parts of an advanced directive using this UCLA one as an example. Each are slightly different. Each have the same purpose if completed as instructed on the document. So on this form, it has an introduction of what is advanced care plan. We sort of covered that. And how to use this directive in the purpose. On this document, and this is something that I like from our document, the first 2 to 4 pages, often I hear that it's tough to get through this document. It's tough and a little emotional. And so again, taking each page as it comes. In the first few pages, at least in this directive, pages 2 to 4, it really asks us to think about our values and goals. One thing that prompted me to move into palliative care is being able to talk to people about values and goals and what makes them, what defines them, what's important to them. I think oftentimes medicine, the medical field is a little guilty of missing that piece. And we move into here are the interventions, here are the treatments. Let's do this, and not really taking into account the person that is at the center of that. And so I find it's one of the privileges of my job to go through some of these questions and learn what brings people joy, what's meaningful to them. And then how does that then inform the plan of care, meaning like treatment and interventions? And how do those things translate into quality of life, which ideally is reflected in such a document? I just want to check in. Can everyone see the screen okay? Is it?
Yes, it's
okay.
There. And I just have another 2 questions.
Sure.
So where do you put these advanced care directives so that the doctor and the hospitals can find it and respect your wishes?
Yes, that's a great question. I'm going to save that for a couple more slides. I do address that.
Yes. Right. And then the other one is any special steps to take when the patient knows different relatives have different opinions on level of care?
That's a good one. That's a good one. I'm going to save that one
Is
too,
that one
because
too? Okay, great.
I
Okay,
believe I'm going to address it in a few slides.
great.
Those are
Thank
really
you.
good questions. Again, this continues on the values and goals. And values and goals are very, very different from person to person. Even within, as that question was kind of alluding to, from family member to family member. Some of the things I'll share with you that I hear is, I enjoy being active, but that treatment, that intervention may require me to be in bed, 90% of the time. Is that something that I'm willing to do? I enjoy eating, but chemo may cause some sores in my mouth or throat, so I will not be able to eat for at least 2 weeks. Is that something that is acceptable to me? I travel a lot, and now I'm kind of dependent on artificial feeding. Is that something that I can still travel with? So kind of those things, and talking to your physicians, to your medical team, is how will this care, how will these interventions impact your quality of life? And some people say, I'm okay with being bedbound, or I'm okay with, changes, physical changes. And I hear a range. I think my goal and the goal of the team that I work with is to make sure people are well informed and make decisions based on, again, being well informed, but also on the medical team side, we need to be well informed on our patient and how they define quality of life. And this continues the values and goals portion. And if you have the document, it's the same pages. So choosing a healthcare agent, and I think, Aisha, that question can be tied into here of if family members have different views on that, and that makes it tricky. And I've experienced picking a healthcare agent can be just as emotional as discussing a plan of care. And if they have differing views from the person, from the patient, from the person that is completing this document. This is why the conversation leading up to the completion of this document is really, really important. And I think I said that the heart of it is communication, but I would say the second heart of it is choosing your healthcare agent. It's so significant. I want to highlight it and not underestimate that, because they will be the extension of your voice. And so having someone that you trust to really hear and understand who you are and your instructions, you'd be able to follow through with those when it comes time, if there is that time it presents itself, to make those decisions and convey those to the medical team. I've heard some people kind of struggle. I have four children, and I'm not sure which to pick, because then what does that mean to pick one over the other? And we talk that through and pick the person that would, again, the person that one trusts and has faith that they will follow through with their role as a healthcare agent, because it is a role of responsibility. And again, the healthcare agent should be aware that they have been appointed this role, again, having a conversation before, and assistance may be needed with this conversation from someone like me, a social worker or a physician, in explaining what it means to be a healthcare agent of that role. And we recommend having one person as the primary agent. You can list a second and a third. And on these forms, I should point out, you can add sheets to them as well. So if there were other people you wanted involved, I really caution against having joint responsibility in these documents for that specific reason, that if there's any conflict in decision making, there may be a delay in treatment or a delay of implementing the instructions that are listed on this healthcare agent. I think we talked about, if you don't have a healthcare agent to name, that's okay. You can leave that part blank. I've had the question of, if someone lives in an extended care facility or assisted living center, They may want to list a staff member from that agency, as long as it's not someone that is part of like your healthcare team that is treating you. That should be fine. I always advise to look at the rules and regulations of that specific facility. And I want to say again, you know, the facility or hospital will make decisions that are based on the best interest of the patient when an advanced care document is not in place. So there's often a lot of things are weighed, and assistance is provided to the healthcare agent. And there's a section on organ and tissue donation. I think one thing I want to highlight that actually just got a question about this a couple weeks ago on body donation. There is in this document, because we do have that service here at UCLA, there's a link there, but there are others as well, other body donation programs. There is an application or a form that does need to be completed for that specific body donation program. I often advise looking at that, reviewing that form, filling it out, and putting that with your advance directive. So when that time comes, your healthcare agent and your medical team, they know that these arrangements have been made. But it's okay if that form isn't completed. This is a question that I got a couple weeks ago, how to go about that, and we were able to get the form completed for that patient. So that's something to think about if it's of interest of having that done ahead of time as well. So how do we make this form legal? You ideally had a great conversation with your doctors, with your treating team, with the people, the family that you've designated as a healthcare agent. And to kind of go back to that question of the family members, maybe there being some, I don't want to say discord, but just different views on what decisions need to be made, or there's just some disagreement there. Again, it goes back to the conversations, talking that through and thinking about if we have such a large, the gap of disagreement is so large, is this asking the hard question, is this the right person to designate as my healthcare agent? And it may be no. I have seen some documents that instead of family, there's a longtime friend or you know, a coworker that's listed because that person, you know, does align with the responsibilities of being a healthcare agent. So that's a hard question to ask. That's where kind of the emotions might come in. But let's say all of that is more or less resolved, and now you're ready to make it legal. So this is the page on this document, at least, and all documents will have a place for you as the person that's completing the form to sign it. Leave that blank until you have your 2 witnesses or a notary. This is what makes the document legal. You need to either sign this document in front of 2 witnesses or have it notarized, one or the other. I oftentimes, this is not a hard or fast rule, this is just from experience. If there's some family complications or a thought that someone's going to dispute this document, I advise going with the notary, that official seal. There's, you know, that notary is generally an unbiased, neutral person. And it just feels a little bit tidier if there's some question about this document being disputed in any way. And the 2 witnesses, and there are some guidelines for being a witness. It can't be just some things I wanna highlight is they need to be over the age of 18. They must know you. They must see you sign the form in your presence. They cannot be the people or person that you designated as your healthcare agent. So for example, I designated my sister as my healthcare agent. She can't sign as a witness. They can't be your healthcare provider. Get that question all the time in clinic and in the hospital. Well, there's so many of you. There's nurses, there's all of you around. Why can't you just witness it? it does put some bias on the document. You know, we're treating you, we're taking care of you. So there might be question of, did we coerce this? Did we color this somehow? And or work at the nursing facility where you live, if you do live in a nursing facility. And it says here, it can't be, one of the witnesses cannot be related to you in any way. So you can have one family member as a witness, again, not the healthcare agent, but the second witness has to be unrelated to you or benefit financially, meaning get any money or property after you die. And so on the left here, you'll see that's the witness page. And then on the right is the notary. So again, one or the other. You don't need both. And so that's the Advanced Healthcare Directive. You also received, and we'll be reviewing the physician's order for life-sustaining treatment, the POLST, and to the question of other states. This one is specific to California. There are others in other states. Sometimes it's called the MOLST. I think it's medical orders for life-sustaining treatment. So you might want to check your specific state. Again, these forms ideally travel with patients. So as healthcare systems are using these more, I think we're a bit more flexible in that sense of if we get one from out of state, we'll still review it with the patient if they're able to participate, or the family that is accompanying, to make sure that everything is still current. And so this form, it comes in the color that you see. It's hot pink on cardstock for a specific reason. It's designed to be eye-catching. It's also designed to kind of force, if you will, for the disciplines you see here, a physician, nurse practitioner, or a physician's assistant to have conversations about life-sustaining treatment with their patient. Quite a few years ago, it was found that some of these conversations weren't being held with these disciplines with their patients, or weren't held to a standard that these orders could be translated from setting to setting, like from clinic, from home to hospital. And so this form was developed to really initiate these conversations, clarify and document the discussions that were being held. In my role, for example, I can, like I'm doing now as a social worker, I can educate, provide this information to you, even help complete parts of it. But in order for it to be a legal valid document, it has to be reviewed by the 3 disciplines you see there and signed with the patient or designated decision maker and the physician or someone from the medical team. And what's different about this than the advanced directive we just reviewed is it has very specific instructions concerning your preferred medical treatment. You'll see that there's 4 main parts. It starts with CPR, then it goes into medical interventions. Part C is artificially administered nutrition, and then the signatures. And this is actually, when people come in with this, it gets translated into an order in the patient's chart. So this is why, it's a very serious document like the advanced directive, but it actually is a physician's order. That's why it needs to be discussed with these disciplines, and it's legally binding across healthcare sites in California.
Before you move on, is
Yes.
a POLST the same as an out-of-hospital DNR?
It's similar, yes. Slightly different form, but yes, it has the same function.
Okay.
Mhm.
And then one other quick question, is a patient emerging with Alzheimer's able to sign an advanced care directive? I guess they're asking before a diagnosis.
Yes, so probably early stage. I would I have a general yes to that. I've met those patients and they still have, as long as they're deemed to have capacity, understand what they're signing, kind of still have some critical thinking. If they have that capacity, then they could sign the document. If the physician, for example, feels that they don't have capacity, then this could be reviewed with the family member or whoever's involved, and it could still be completed.
Okay, thank you.
And some indications for a pulse, it's not designed for everyone. That's another difference than the advanced healthcare directive. The advanced healthcare directive can be completed by any adult age 18 plus, as well as emancipated minors. The pulse was designed for people that have a serious illness, are medically frail, and have a chronic progressive condition. Kind of how you just described the question that was just asked about Alzheimer's, about dementia. Kind of the guiding question for us, and my apologies if this sounds a bit crude, is that we wouldn't be surprised if this person died within the next year. That's how seriously ill and frail they are. I often still introduce this document to people that don't necessarily meet this criteria. I think it's a document of value to help with those advanced care planning conversations and really think about the interventions that we may be asked to make decisions on later on. And as the slide showed a few slides ago, I think there was a slide with someone being rushed into the ER. Thinking about CPR and those interventions that might be implemented, and discussing them with your medical teams of what is the likelihood of these interventions being successful. And this is, although we've been discussing this, I just wanted to put a slide here of kind of illustrating the differences of the advanced directive and the POLST in a different way. Ideally, they complement each other and reflect the same instructions. Sometimes we see the advanced directive maybe was completed 10 years ago and the POLST is more recent, and there's some discrepancy. If there's some discrepancy, I take that as an opportunity to have a discussion about what are the current goals. Do we need to update other things? Do we need to have more updated conversations with the medical teams? And so you see a little bit of the difference and similarities. And under advanced directive, it requires interpretation. Again, can't predict every scenario, therefore the POLST gets a bit more specific. And the POLST, there is only one form in California. So unlike the advanced directive, like I said earlier, you can Google and at least 50 will come up, different kinds. The POLST, there is only one. And there, I believe I have the website for Compassionate Care of California that helped really spearhead and develop this form, so you can get more information on that. I was just pausing to see if there are any questions. So advanced care planning, when to revisit the advanced directive, even the POLST. Like I had said in an earlier slide, this is an ongoing process. It may not be just one conversation, maybe multiple conversations. And if you have the document done, completed, it's sealed, it's still really good, and I really encourage to review it. And it's really important to make sure that it reflects who you are. Again, I completed my directive about, 15 years ago, and I've looked at it since. And I need to look at it again to see if there are any changes. I'm in a different point in my life. And so some things may change. I think what we call, kind of our jargon, our goals of care, what we hope for ourselves in response for treatment interventions, those are often very fluid. I may accept different interventions or different outcomes than I did when, I was, 10 years ago, when I was in my 40s, or 20 years ago in my 30s. It would be different. And so we really want to make sure that we keep the instructions as current as possible. So it's recommended to review these documents and have related conversations when there's a new medical condition or scheduled surgery, change in family or agent circumstances. Perhaps the healthcare agent that's listed has their own medical needs and is unable to fill that role. They've maybe died, they've moved, or they've decided they can't take on that role anymore. And as I say that on the Advanced Healthcare Directive, you can list, a couple people. So even let's say you have agent number 1, agent number 2. If number 1 says, I can't do this, I'm moving out of the country, I don't know how available I'll be, you don't have to make a whole new directive. You still have agent number 2 listed, and if that's current, that's okay, that can stand. Again, relocation, you have new providers. Maybe you move to a new health system, or you have, your doctor has retired, you have a new doctor. It's a good time to revisit the advanced care planning conversations and provide those documents if you haven't already. Oftentimes, or sometimes, physicians may not initiate these conversations. It may come from you. So I'm really grateful that you're taking in this information so you can have some of the language to share with your providers and open up that dialogue. And at a minimum, every 5 years. 5 years it's been found to be a good amount of time to review. And if nothing has changed, you continue on and leave the documents as such. They don't expire. There isn't a time limit on them. So once you complete them, they stand unless you make new documents. So I see in patient charts sometimes where they have maybe 3 advanced directives because they've made some changes. We take the most current, and the most current that was completed, meaning witnessed or notarized or on the post, all the signatures are there. So I think there was the question about, what do I do with the document now? I've completed my directive, I've completed my post. What do I do with it? I'm a big believer it should be shared with your world, whoever is in that. You should always keep the originals, or keep it, or give the original to someone that you trust will keep it. Definitely a copy to your healthcare agent so they know they have it. If someone comes through the ER, they're not going to have this document on their person. It's not something that is carried around. And so that healthcare agent may be called upon to bring in the directive and the post. Any other relevant family members, someone that will come and visit you, someone that can make the form accessible or provide it to your treating teams. Any agencies you're a part of, senior service agencies, organizations that you spend a lot of time at or volunteer at or work at, things like that. Primary and specialist physicians. Here at UCLA, if I upload it in our system, it's in your chart. So any clinic, any UCLA affiliated clinic or hospital can see that. And so if you have any relationships or doctors outside of that, then I would advise sharing these documents with them as well. And so the documents here at UCLA can be uploaded in the clinic, in the hospital, in admissions, and once they're in, they're in. And someone that will likely visit you in the hospital, someone that will be there and provide these documents. And I want to wrap it up by showing some stats. Stats might be a little bit dated, but not too much. I think they pretty much still stand to really highlight the importance of advanced directives. So studies show that only about 25 of Americans have recorded their medical care wishes in a legal document, such as the ones we discussed today. However, when studied, 70% or more of Californians would prefer to die at home. However, over 60% currently die in a facility or a hospital, not their desired location. When I read that that study, that the stats. It was really it impacted me and really increased my passion for sharing this information and facilitating these conversations and document completion. I still hold the conversations, the discussions that we have with our family, our loved ones, is a priority. And so hopefully you found this information helpful as well. I think we have about 7 minutes left for any questions. I did want to, I think these are some of the references that are at the end of my slides, that the slide deck that you'll get, just to kind of reference them, have my contact information, my email is probably the best way to reach me if you'd like to reach out with any other questions. And at the start of this, I had the list of the Go Wish game. That's just one of things you can do to, like, there are exercises to think about what is quality of life for me, what's important for me to maintain or for my family to know. Just some references here at UCLA. And also there's this website where there's another option for advanced directives. They offer education as well. And Coalition for Compassionate Care of California, those are the ones that spearheaded the post. So this is for your information if you'd like to do a little bit more research, read up a little bit more, or if you have any questions that you'd like to reach out to me with.
Thank you. So this important topic, I did my advanced care directive because I know it's a very scary thing to talk about, but I personally have my own wishes that I want to share my loved ones know about. So it's definitely something anyone can do at any age to make sure that you have your wishes the way you want them to be and your things carried out. So any questions? Feel free to unmute yourself. Yes, I will be sending out this recording as soon as I upload it to YouTube. I'll include the slides and the forms so you have those as well. But go ahead and feel free to unmute yourself if you have any questions.
While you're thinking about your questions, I saw something. I'm looking at the chat as well. I think it's if I'm pronouncing it correctly, Sid brought up a really good point. Something that doesn't make it in my presentation because I'm focused on the Advanced Healthcare Directive, but it's the finances. I think also considering like a power of attorney for finances. I'm limited on it's a little bit outside of my scope of practice, so I can't advise that much on finances, but something to think about as well is, a kind of like bank accounts, having, a person that can access those, having, where are the passwords for like Social Security, thinking about representative payee, and thinking about, the financial institutions that you have relationships with, how, if needed, how can someone manage your accounts if you're unable to do so. And I was thinking about like safety, right? We live in the land of hacking and all of that and those sorts of things. So really speaking directly to your financial institution, like your bank, credit cards, things like that, of in that event, what forms need to be completed.
And I will say, just to piggyback off that, our health insurance has ARAG Legal. And since open enrollment is coming up, I will tell everyone as a personal thing, ARAG Legal, I believe, is $10 or $12 a month. And through ARAG, I was able to talk to an attorney to do my own trust and financial planning, which normally would cost probably thousands of dollars to talk to an attorney. But since you're doing open enrollment and you calculate $10 a month for 12 months, you can at least get one good thing out of it. So if you're thinking of ARAG Legal for open enrollment, it's definitely something where your financial provider or Fidelity, but you can talk to an attorney through the insurance that UC offers for retirement. So
Aisha, I'm glad you brought that up. I'm a user of that service as well. And so yeah, it's a great service. Take advantage of that.
Yeah. Okay, as I mentioned, feel free to unmute yourself if you have any questions.
Can you hear me?
Yes, we can,
Yes.
William.
I have a question about you, a first or second agent who is a non-native English speaker. I wonder if there are Japanese versions of these various documents.
Yes, there is. And I can, I think it's on my reference page. Thank you for bringing that up. I missed that piece. Thank you. There are, there's a website, Prepare for Your Care. And I can email you, Aisha, the specific link so you can send it out. They have really nice bilingual documents where it's both in English and in this case, Japanese, or they're obviously they're limited on the amount of languages, but it's a pretty good list. That's the best reference or resource I have found so far, that they're bilingual, so that when that person, for example, that maybe English isn't their first language, they can read it. Also, us that maybe don't speak Japanese can read it, and so there are some really good bilingual documents out there. And I should mention the Post. The Post comes in a lot of different languages as well. However, it has to be completed in English. But then now I'm getting into the weeds a little bit. But then let's say in Japanese, that can be stapled to the document so the person can follow along on what you've checked off.
It's also necessary because I'm in Japan much of the time.
Yes.
So if you can send me that, Delia,
Yep.
but maybe by the end of today, I'll make sure I can.
I'm gonna send it right after this. Otherwise,
okay.
I run the risk of forgetting, so I'll send it right away. Yeah.
Okay, great. Any other questions?
Excuse me. A question came up about this is George Abe. A question came up about any special tips in the case of close relatives have different opinions on level of care, or let's say different religious opinions. Any tips on how to mediate that?
Yes, I think, like I said earlier, it's the conversations that are really important, and some of those conversations can be really challenging. I think if there's really strong differing opinions, if religion or other moral or ethical thoughts can influence that as well. If the family themselves can't or are challenged by navigating those, I would suggest maybe including the physician or someone that you trust from your treating team. Perhaps in the clinic or in the hospital, there's a social worker or a chaplain that could be involved. I've seen also some family members, if they're connected to, a faith community, they may have, a rabbi, a priest, a pastor, someone that could maybe help with those conversations or offer some guidance on how to have those conversations. So hopefully that's helpful.
Thank you.
You're welcome. Thank you for the question.
Okay, any other question? Let me see who's got a hand up or anything. Okay, last chance before we get about the rest of our day. Okay. So again, once I get this uploaded to the cloud and then downloaded to the cloud from the cloud and put on the YouTube channel, I will follow up via email with all the attachments about the different languages, and then give you Delia's contact information. We've done this program in the past, and I really appreciate you doing this again for our group. And we'll be in touch.
Thank you. Thank you all for coming and participating. Thank you for your questions and I'm noticing all your thank yous in the chat. So that's much appreciated.
Okay. Take care, everyone.
Take care.
Bye.
Bye.